Now, the Joint Commission's revision of the emergency management standards was developed independently of the Gilmore Commission efforts. But this just goes to highlight that this is an issue that isn't going to go away. The world is an increasingly dangerous place, and hospitals now have an opportunity to collaborate with their community partners to increase their level of preparedness. The Joint Commission presented these new emergency management standards to the Gilmore Commission in late March. A JCSN field crew was also present and interviewed 3 panel members from the Gilmore Commission about issues related to WMD. Let's start now by hearing what they had to say.
Well, we have a long, long way to go. We need much more coordination among the agencies, not only at the national level, but even more important at the local level. And from my perspective, because I'm interested particularly in the health aspects, a lot more work with regard to the medical profession, hospitals, and their relationships to public health and to the other first responders.
Well, one of the things that the panel is doing is it presents to the President and the Congress suggestions of what are priorities, what things should be done first, how things need to be coordinated, and all of that then will filter down to the people actually on the front lines trying to get these things done.
One of the major goals of local and state government in the results of this panel is really recognizing that if the federal government understands the role of the first responders in a domestic terrorist event, that they'll realize that the first 24 hours or maybe even 2 or 3 days, it's going to be local responders, local health care and hospitals that will be taking care of the event, and that they should really be supporting us financially.
And joining us first today are Scott Lillibridge and Christy Koenig. Dr. Lillibridge is the director of the Bioterrorism Preparedness and Response Program at the CDC. This is a new office charged with enhancing CDC's capacities to assist state and local health departments in responding to bioterrorism. In addition to infectious disease concerns, other CDC efforts in support of this program include consideration for chemical terrorism, a national pharmaceutical stockpile, health communication and training, and national lab enhancement. The program was initiated in January 1999. Dr. Christy Koenig, a familiar face to our VA subscribers, is a board-certified emergency physician and director of the Emergency Management Strategic Healthcare Group in the Department of Veterans Affairs. She serves as the principal advisor on emergency management and disaster medicine to the Office of the Undersecretary for Health in the Veterans Health Administration, Department of Veterans Affairs. And Scott and Christy, I want to thank both of you for being with us today.
Thanks
it's our pleasure. Nice to have you both. So why don't we start out with your reaction to the Gilmore Commission and what they had to say?
Well, I'd like to applaud the work of the Gilmore Commission. First of all, it helped broaden our understanding beyond first responder in response to terrorism events to include or bring in concern for the hospital and medical community. I think it's extremely important that they get involved in this overall preparedness effort.
And I'm really pleased to see this being addressed at the national level. One of the things that comes out in this report is that we're now focusing on people who work in hospitals, whereas traditionally we looked at first responders as fire department and police personnel and paramedics. We're now looking at people who are in a hospital setting who might be the first people to contact these casualties.
All right, thank you very much. Now, there are dozens of federal agencies dedicated to various sorts of emergency management. Every state has their own agencies. So why then should a hospital get involved in helping their entire community to prepare?
Well, I think it's easy. In a community that responds to a disaster or a public health emergency, often we respond with all those parts to get to where we need to go. It's important to think of hospitals as part of that overall planning process.
Hospitals can no longer afford to plan in a vacuum. They must be part of the community, because an event such as a WMD event is going to involve everybody in the community. It will be too big for a single facility to take care of. So in addition to helping within the community will be helping the hospital. And it's very important to know what resources are out there, because this is going to be an overwhelming event.
Exactly, and hospitals are often seen as a community resource. The poison control centers there, the hub of EMS services, and other things that happen within the hospital environment.
If your hospital is still standing, it's kind of out there like a beacon, and people will come to you if they can get there. So you really need to be prepared and know what resources you can gain from your community and what you can give to your community.
So if the communities are having to coordinate, what improvements have been made recently in coordination among the federal agencies?
Good question. There's been a number of interagency forum training opportunities. In particular, the National Disaster Preparedness Office of the FBI and Department of Justice has provided a forum for federal coordination.
One of the things I'd like to mention from the perspective of the Department of Veterans Affairs, and I know all of you are out there at all 173 of our facilities watching this tape right now, is that we should be viewed as a community resource. Although we are federal facilities, we have a presence in the local community. We want to partner with our communities. So don't forget to turn to your VA hospitals and include personnel in VA hospitals when you're doing your planning within the community.
All right, panel, thank you very much. Before introducing you to the remainder of our faculty, let's return to the videotape to hear the panel members from the Gilmore Commission discuss its progress to date.
The Commission on Preparedness domestically for weapons of mass destruction started a little over 2 years ago. We're now in our third year. We've issued 2 preliminary reports, and our third report is due at the end of calendar 2001. The Commission has looked carefully at national programs, state and local programs, and we're very lucky we have a makeup that includes people from almost all of the disciplines that are involved in preparedness.
Well, what the panel typically does is it will say, here's an area that we have identified that needs to be addressed. Sometimes we'll have specific suggestions on how to address it. Sometimes we just say, look, this is something that needs to be addressed, and you need to put a panel together of experts in that area to decide how best to address it. So it's those kind of sort of broader kinds of recommendations that are coming out of this panel.
The panel recognizes that we have some very specific pieces of the system that we have to strengthen. Some of those are in our legal system or changes in laws. Others are in the structure at the federal level. Currently, we have over 4 dozen entities in the federal government that touch this issue in some way. And if we coordinate and consolidate those, maybe we can be spending less money and get more clout at the federal level. And then I believe there's a real recognition both by folks in the federal government but also those who bring local expertise to this panel that if local and state government is not prepared for the first hours and days of an event, that the costs will be much greater in the long run. And so one of the major points of this panel will be to speak to the importance of capacity at the local level.
I think that the interviews that we had demonstrated that there was a very considerable amount of interest in problems of dealing with weapons of mass destruction and the various components thereof. What surprised me a little bit was the notion that people were focused so much on big catastrophic events, tens of thousands of people being infected by something, or a chemical thing that would affect thousands of people. I don't believe that's the scenario that's likely to take place. I think in both chemical and biological areas, the problem is going to be small numbers of individuals spreading to a larger number of individuals over a significant period of time. And the challenge is going to be, will you recognize those early cases well enough so that you can interfere with what's going on and stop it, as opposed to some big cataclysm where you're going to suddenly have the hospital or the public health system overwhelmed by tens of thousands of patients.
We're going to have to be working as a community, because if we have terrorism, it's not going to just affect the hospital, the healthcare professional, the public health official. It's going to be affecting the whole community, and we will have to be working together in order to address that threat.
Joining us now is Dr. Robert Wise. Dr. Wise is the Vice President for Standards for the Joint Commission. In this position, he is responsible for the development and implementation of standards for all accreditation programs, which include hospitals, home care, long-term care, ambulatory care, behavioral health care, health networks, and clinical laboratories. Bob, welcome to the program.
Thank you.
Nice to have you. We're going to bring you right into the conversation, Bob. The intent of EC 1.4, the revised emergency management standards that viewers can see on pages 15 and 16 of their viewer's guide, requires that the plan defines and, when appropriate, integrates the organization's role with community-wide response agencies. So what's the rationale behind this requirement?
The Joint Commission has had a long history of encouraging hospitals to be involved with emergency preparedness. But the old standards, which were emergency preparedness, tended to create more of a stagnant plan. A hospital might prepare for a tornado, might prepare for a hurricane. It was clear that we needed a more flexible approach to deal with the many types of issues that could overwhelm the resources. So we really migrated from an emergency preparedness to an emergency management. We've achieved this through three basic ways, among some others. The first one is the development of an incident command structure. The other one is that there's an expectation that the processes that a hospital develop be able to interact and operate with what the community is doing if they are also involved in the emergency preparations. And the last one is to be involved with a regular hazard vulnerability analysis. And that's where the organization is going out into the environment and trying to understand exactly what is the vulnerability they have and to make sure that their plan is able to respond to it. The goal of this has been to produce a scalable and a scalable response, that no matter what occurs, that there will be an ability for the hospital to respond, and that has been achieved.
And I really want to compliment the Joint Commission on your leadership in putting these new comprehensive emergency management standards into place. This is really groundbreaking because it's the first time that the emergency management community and the hospital or healthcare community is speaking the same language. We're now both talking ICS, Incident Command System, or Incident Management System. We're now all doing a hazards vulnerability management analysis together, and we're all working within the entire community to speak the same language. So this is going to be very, very helpful, especially for healthcare facilities preparing for such a catastrophic event as weapons of mass destruction.
All right, thank you, Christy. We'll be touching on similar issues throughout the program. And rounding out today's panel is Deborah Kim. Debbie is Program Manager for Health Sciences Emergency Management at the University of Utah Health Sciences Center, and also is Program Manager for Emergency Preparedness and Hazardous Materials for the University of Utah Hospital and Clinics. She was appointed by the Governor of Utah to serve on the Citizens Advisory Commission on Chemical Weapons Demilitarization and is a clinical consultant to the Utah Poison Control Center. Additionally, Debbie is a member of the Terrorism Prevention Working Group, National Pharmaceutical Stockpile Planning Group, and the Metropolitan Medical Response System Project, and the National Disaster Medical System in Salt Lake City, Utah. Now, Debbie, welcome to the program. We're very glad to have you. We're going to bring you also right into the conversation. During that last tape piece, when Kathleen O'Brien mentioned some very specific pieces of the system that need strengthening, what might she be referring to?
My best guess is she's referring to what she has observed firsthand, and that there are, I think she counted a number of agencies that were involved in weapons of mass destruction or WMD training. The frustration for the local planners has been that a lot of the training has been to first responders and didn't really integrate the medical community, specifically the hospital community. A lot of the content really wasn't hospital specific, and more importantly, our framework, or how we relate, is really based around the Joint Commission standards, and we did not have that opportunity to integrate the standards. There was a lot of duplication. One agency would come out, do the training, and there would be another agency out several months later doing the same thing, and the perception within the EMS community is these guys don't talk to each other, and that was really unfortunate. I think she was also talking about the need to fill the gap between the federal response and the state response, and have them understand what their role is a little bit better, and perhaps strengthen the state response, because as she correctly pointed out, when an emergency happens, the federal resources are not going to be there showing up right away.
Well, panel, let's bring everyone else into the conversation. What are some other issues regarding the pieces of the system that need strengthening?
I think there's a number of things to look at. For the first part of our national preparedness efforts for terrorism, we really involved and focused on first responders, fire, law enforcement. As we became more mature in this effort, we began to bring in the health community, the public health, and the medical community. And I really applaud these efforts of the Joint Commission to bring in hospital preparedness, or comprehensive hospital emergency management, to begin to deal with this, to bolster up the community as a whole.
All right, thank you, panel, very much. While in Washington, D.C., our JCSN field crews also paid a visit to Congressman Wayne Gilchrist, who represents the 1st District of Maryland. Congressman Gilchrist is one of the co-sponsors of H.R. Bill 525, also known as the Defense of the Environment Act of 1999. Congressman Gilchrist was kind enough to spend a few moments discussing the bill with our field crew for your benefit. The bill, in essence, would create an entity within the executive branch reportable to Congress to oversee and coordinate the activities of numerous federal agencies whose purpose is to help protect the nation from all sorts of disasters, many of which your facility's emergency management plans would be designed to help mitigate. Let's take a look.
I think for a number of years, a number of members, because they represent diverse districts around the country, and they have witnessed some pretty horrific disasters, from the Merrill Federal Building in Oklahoma to earthquakes in California to tornadoes in the southeast to pretty fierce hurricanes. So man-made and natural disasters put a heavy strain on the first responders to these incidents, and then the follow-up with the state agencies and the federal agencies. So what a number of us and staff have been discussing for a good period of time is how we can develop a very comprehensive, easy communication flow, succinct chain of events that can be coordinated within the federal government, the state government, the local government, and the first responders, those civilians on the scene, to better able serve the needs of people in time of crisis. The bill has 35 other members of Congress that are working pretty aggressively on it. The first hearing will be May the 10th, and at which time several hundred members will be exposed to this. The markup, which means we'll vote on it in the committee, will come shortly after that. We hope the next couple of weeks, sometime the end of May, certainly the first part of June, where it will be voted favorably out of the committee. And then sometime, we suspect in the July-August timeframe, this will pass the House of Representatives. The bill develops a council in the White House that coordinates with numerous federal agencies to provide expertise, money, training, and a structure for coordinating with all the various federal, state, local agencies, and the private sector throughout the country. The bill will coordinate America to be able to respond in a very efficient way to meet the needs of the health and safety of Americans. And the other thing that I think is the most important piece of this bill, not only that it creates a new office in the White House, and not only, which is needed, that it coordinates all of the various activities from FEMA to the CIA to the health agencies throughout the government, but it gets that information and backs up the local firemen, the local doctor, the local nurses, the local police forces, all the local people that are going to be exposed to this thing. Many, if not most, communities where there is a paid fire department or a voluntary fire department coordinate with the police, with the hospitals, with the doctors, and they run mock crises, the full range of types of things that could happen. And what the bill will do is ensure that that can continue, but you have better communication between the various agencies as to what exactly they do during these mock events, and the upgrade in training, because the increased amount of dollars, not only from the amount of money that's going to be authorized out of this bill, but the increase in dollars that can come by simple coordination between the federal agencies.
So, panel, let's get your comments to what Congressman Gilchrist had to say.
I think it's really important that this coordination and communication is being addressed at the federal level, but we need to remember that disasters are local. You need to be prepared to respond in your local communities at the local level. And they're talking a lot about people who go out to the scene, but for this audience of you, those of you working in hospitals, again, you may be the first responders. And so we have to see what we can do at the hospital setting when we receive casualties of a chemical incident, or perhaps when it's a biological incident that might not be known for many days and people are coming in with flu-like symptoms. How can we get that assistance from the state and federal levels? How do we hook into that communication and coordination? I wonder how many of you know your emergency planners and your public health department personnel within your community. That would be a very good start. Meet those people.
Exactly. I wanted to make 2 points. One is that the emphasis on local preparedness and planning is extremely important. In all the disasters that I've been to, the local community had to stand alone for a period of hours or days until the federal emergency management system geared up to respond to the initial assessments, to get organized, and that the investment in local planning or emergency management will pay off in big dividends in terms of response for your community locally. The second thing is that looking at hospital mobilization or emergency planning as a whole, it's pretty clear that as we begin to look at how hospitals might be a community resource or be involved in a large-scale disaster, that many departments within the hospital have to respond, not only the emergency department, but the laundry, the food service, the administrative components of a hospital. In a large-scale disaster or emergency, all these components will be involved.
It's not just the emergency room.
Correct.
Okay.
Let me just pick up on the role of the hospital, because I think the hospital is also going to have to rethink some of its role, and that role is how it fits into the entire community. There are 2 parts. One is that the hospital has to understand that in this type of situation, it will be a hospital among many hospitals, and those hospitals need to work together, whether to exchange resources, information, or whatever. And also the community will be operating as a whole, and the role that the hospital plays must be integrated into that overall response, and they have to see themselves and search out a place where they fit into that overall process.
The other point that I would make is there's not really good standards for what you need in a hospital to take care of casualties of a weapons of mass destruction event, particularly for chemically exposed casualties. Many of these rules and regulations that have come out from, say, OSHA and NIOSH were developed for first responders who go out and respond to a scene, not for patients coming into a hospital. So we have to figure out what to do in a healthcare setting. And one of the things we're doing actually in the Department of Veterans Affairs to address this issue of what should be the essential standard across the entire country is we've put together a multidisciplinary technical advisory committee with people, not just VA experts, but also everybody who's involved with terrorism, representatives from the NDPO, representatives from CDC, representatives from HHS, everybody who might have a say, and we're trying to come up with our best scientific evaluation of what would work in a hospital setting, which is really not out there yet. So there's hope on the horizon.
We experienced everything that the panel has discussed so far in Salt Lake City, both on a local level and certainly on a national level with the chemical stockpile program. For many of the viewers who don't know, Salt Lake City is very close to Tooele Army Depot, which has had roughly half the nation's stockpile of nerve and mustard agent stored right in our backyard. And a number of years ago, we started to look at this problem collectively as hospitals. On page 23 of the viewer's guide, you'll see a document which we developed as a collaborative effort with the hospitals, beginning to address some of the issues that Christy is talking about in terms of what were our standards and what did we need minimally. The document in your viewer's guide describes some of the standards we looked at, including the NFPA, National Fire Protection Agency standards, and some OSHA standards as well. It's a beginning step. This is the second production of this document, but it's what we use in our state and locally because, as Christy correctly points out, there is nothing else out there, and we had to do it ourselves.
All right. So, Scott, how is the CDC working with the public health establishment to help emergency management activities, and then how might that filter down to the local hospitals?
Good question. We have a program. It's in its third year that helps working with state and local health departments to increase their capacity to deal with public health emergencies, largely related to bioterrorism, but other types of public health emergencies. Capacities that we're helping build with the state and local community, public health or health departments, include the capacities for enhanced laboratory detection, enhanced disease surveillance activity, planning, communications, and a capacity that we're developing to help local health departments communicate with state health departments called our Health Alert Network that allows early alerting, distance-based learning.
All right, thank you, panel. Now, it seems like this is going to be much easier for hospitals in large metropolitan areas than it will be for our smaller and more rural subscribers. Large cities generally have several agencies that have already done much of the work that the Joint Commission is going to want to see, and these larger hospitals mostly just have to think through their existing plans and then integrate with other agencies within their communities. So this question, panel, is for those hospitals in communities small enough where it's likely that nothing's been done yet. How can a hospital partner with its community to come together to form emergency management plans?
I think that's a really important question, and it is a lot more difficult in a rural community where you have fewer resources, but you're still at risk. This type of terrorist event could really happen anywhere, we know, even in a small community. And one of the things I would like to offer is, again, through the Department of Veterans Affairs, we have personnel virtually throughout the entire country with this large integrated healthcare system. And if you have a VA hospital in your area, you can contact the area emergency manager in that hospital, and that person can help you get hooked up with resources in the community so that you can figure out who to work with and sort of augment what you have.
We've been really successful with doing that in my community. I work very closely with two emergency planners which represent the larger institutions, and one of them is the Veterans Hospital. I just also want to point out that within every community there is a hazardous materials commission called the LEPC, the Local Emergency Planning Committee. And believe it or not, hospitals have to participate in this. This comes out of SARA Title III, which was passed in the late 1970s. And this was an early attempt at really integrating the hospitals with the industry community. What hospitals have to do is actually look at their role and where people may be taken during a disaster. And these people are a good place to start, and they're a local resource, and most importantly, they're free.
I'd like to add one thing to my colleagues, is that most local communities, cities or counties, have an emergency management capacity focused person, and that can be of great help to hospitals doing their planning. Also, most counties or cities have a health officer, either a public health officer or a local district health officer, who can be quite helpful, that may be actually plugged into some of these CDC initiatives that are in progress.
All right.
Jan, it's also worthwhile noting that the Joint Commission has a requirement that twice a year the emergency management plan be executed. This is a great opportunity for the hospital to coordinate with the community to do one of those executions of the plan. Great way to get to know the community, who they are, and have a chance to work together.
So, panel, who then should be involved in emergency management?
I think the entire community needs to be involved. The vital sectors that help support the daily activities in a community will be stressed at the time of an emergency. We'll need to come together, have contingency plans to keep operating.
What about from a hospital standpoint, as far as getting physicians involved, administration involved? Who all needs to be involved in a hospital?
Again, everybody. Everybody needs to know his or her role when a crisis hits. And this is one of the really important points of the new Joint Commission standards, that an incident management system within the hospital is now required. This has been done in the community for years and years and years, very successfully, but it's rather new language and a new system for the hospital. Once you put an incident command system in place, and there are several, for example, the Hospital Emergency Incident Command System, or HICS, in the hospital, it gives you that command and control structure that can expand and contract so that you can really manage anything through this system.
And it's not just dependent on one person being there, which I think is really, really important. The neat thing about HICS is that it has a structure that people can build on, and we have found it to be very successful in our facility. You asked a question, Janet, about who needs to be involved. That's a very good question. Certainly administration needs to be involved to be able to provide you the appropriate support. But I think the question that people aren't asking here is how do we get the physicians involved? And those are people we just can't do without. There are, people have wrestled with this issue of how do I get the docs involved. We've taken a couple different approaches. You can be mean and attach it to their...
Doesn't get you very far, though, does it?
Being mean is not a good thing. And you can say, if you don't come to training, you can't practice here. That doesn't work. Or you can use the reward system, which I think is a better approach, and recognizing that physicians are very busy. They're under tremendous pressure to see a lot of patients. I think that, giving them some compensation for their time, and that needs to be built into the budget process, and recognition for their skills. It might be a better way to go, but you can't plan around them. You have to include them. And I think the trick is to find the people that are actually interested in it, because admittedly, not all docs are going to be interested.
I agree. You really need a champion within the hospital to lead the charge. Unfortunately, the reality often is it takes a disaster for people to wake up and get interested. And you really can't afford to wait for that.
That's a good point.
Yeah. I do want to emphasize the need to get the medical staff involved. They are not necessarily the easiest group to be involved, as we have heard, as we have gone on many surveys. But the risk, if you don't make the effort and you don't do it in the pre-planning, is that when the emergency occurs, you will have one structure, the incident command structure, that takes care of it in one way, and you may have a group of uninvolved physicians who, when they see an emergency, it is typical for them to pick up. And you'll then have two potential people trying to lead a problem when, in fact, this is the time when you need to be well coordinated and doing exactly what has to be done as quickly as possible.
Remember, too, the old way of looking at emergency management had to do with planning for the train crash or the bus accident. And what that is a trauma event. And most physicians, surgeons, ER docs are very good. They know how to take care of patients. But when you expand the event to a non-trauma event, now we're talking weapons of mass destruction, the rules change. And this is not something that most physicians learn in medical school, right, Scott?
Exactly.
Quickly, Scott, we've got to move on.
Okay.
Go ahead.
Quickly, I would say that we've moved from one-dimensional disaster planning, that it was involving the emergency department, into all the sectors, medical records, hospital. Certainly important to have physicians involved. But all those capacities need to work in these type of emergencies in the future.
All right, very good points. Thank you, panel, very much. We've got a final piece featuring the Gilmore Commission panel members before moving forward and concentrating on what individual hospitals already in compliance are doing and how they're working together both strengthens their individual facilities and satisfies the intent of the revised emergency management standard.
One of the things that needs to be done now before an event ever occurs is just to get communications going, for us to know who the players are, who in a hospital is going to be the ones that are going to be responding to or dealing with the terrorist event, the victims, also to get surveillance systems set up. We won't know what's happening unless we have some kind of a system where individual physicians or individual healthcare practitioners can report it back to some kind of a centralized authority to say, I've seen 2 patients, and gee, this person over there has seen a couple, and put it all together and say, something's going on that's not normal.
Hospitals have a real opportunity to become leaders in disaster planning. I think that we've heard presentations from the American Medical Association, whose House of Delegates have endorsed a major approach to disaster planning, and they'll be working through their county and state medical societies to get the medical community involved in it. The CDC is working with the public health establishment, and I think that by and large you'll see these come together. So if the hospital decides to take some leadership, I think it'll find partners.
One of the primary things that we're trying to put together is just a response plan. What will we do in Iowa should some of these terrorist events actually occur? We're trying to integrate that into our overall disaster plan because many of the things are going to be very similar, whether, for example, a truck overturns releasing a chemical or whether somebody releases a chemical deliberately, the response is going to be much the same for a large piece of that. So we're going to put that into our overall response plan, our emergency plan, but then there will be pieces that are different because there will be this terrorist component, a component of criminal response, etc.
In our training, we've met with hospital administrators, and early in the training we realized that the hospitals had their emergency protocols and our police and fire had our emergency protocols, but they weren't really synchronized. And this training has given us an opportunity to understand what the needs of the hospitals are, how the triaging by the first responders and coordination with our medical personnel will really help us if such an event happens in our city.
The biggest thing is just to know who your local public health officials are. Get to know them. Know how to get a hold of them in an emergency. Know at what level you should be calling them. Do I call them on a suspicion, or do I wait for a diagnosis? And I think we'd all say no. Call us the minute you have a suspicion.
I believe that most local governments will be sympathetic partners and will really try to work together to figure out how to get this planning done in a way that still allows hospitals to get their primary job of caring for the people in the community.
All of those plans need to be put together by individual hospitals, but have to be coordinated between hospitals and with the public health entities and with the disaster response teams, and perhaps even with federal teams, which might need to come in to booster the local and the state response capabilities.
I would say that our professionals, whether that's medical profession or police and fire, felt very confident about their own protocols. And they didn't really appreciate the need to coordinate those with other professions. And so the benefit of this training and really explicitly understanding the skills and capacities of the other professions really now are helping them work together.
I think the federal government has several responsibilities. They need to set up, for example, the environment, the way in which we get at what is necessary, what needs to be done at a local level, what needs to be done at a state level, and what is a federal authority. And that you have to bring all those people together to say, okay, I will take on this responsibility, but what I need from you is this.
Panel, any comments?
I want to really emphasize what they're saying about communications and coordination at the local level. Again, if you plan in a vacuum at the hospital, others in the community will be making assumptions that you're not aware of. The nursing home down the street may have in their plan to send you all their patients, and you don't even know that that's going to happen. You may be depending on the same resource that a hospital down the street is depending on when you need it in a type of crisis. So you must communicate and coordinate your plans within the entire community.
Exactly. I'd like to pick up on some of the words of Patricia Quinlisk, one of the panelists that were speaking from the Gilmore Commission, was that hospitals may be the early sites of presentations of some of these types of emergencies, and that if they're not involved in the early detection and planning for a response like this, we're going to miss an opportunity for early response.
Very good point.
Very often, Scott, just to sort of follow through on what you've been saying, one of the things we've noticed is that we've been operating in our own little hospital world for a very long time, and it wasn't until some of this WMD training came along that we actually found out who our partners were in the health department, and they really didn't know who we were. So this has really started the communication process between the two of us, and especially in our community as the Olympics get closer, this has become real important.
Extremely important. This has brought the first dialogue in between merging public health and medical in my past 10 years at CDC.
Yeah. And this issue of surveillance that was just mentioned in the discussion is critical, because if you're working in a hospital and you see a patient, say, with flu-like symptoms, you may not know that every other hospital in the community is also seeing a few of those patients, and this is really a bioterrorism event unless you're communicating together and have surveillance in place. That's one of the things we're actually addressing in the technical advisory committee that I mentioned before with the Department of Veterans Affairs, is how can we put in place this surveillance in coordination with our partners at CDC across the entire country to pick up on things early so that it doesn't go unrecognized and create a bigger public health problem than it otherwise might.
All right, panel, thank you very much. Well, what we've seen so far is that lots of people are working on this already, obviously, and there is movement to get some funding down to where it will help our subscribers. But we're also hearing that help is not so imminent that hospitals can just wait for it, quite the contrary. So here we are again, the do more with less cliche. What are some ways to get all of this done without affecting the hospital's primary job, providing health and medical care? That's a toughie for some hospitals.
One of the ways that can be done is that you start with more routine matters. Routine matters, though, that might also involve scarce resources. A typical one might be the need of a negative pressure room. A hospital may have one negative pressure room and it's full. But have they taken the time to then work out in the community who has another? If in fact someone comes through the door that they now need to treat another 2 or 3 people who have require respiratory isolation, do they have to start picking up the phone and scrambling to figure out, you know, now do I call them or them? But they should have made that in advance. And by working on the routine stuff early on, they are setting the stage for then slowly developing the relationships and beginning to solve the more complex issues that's going to come.
One of the things that I think Bob is alluding to is the development of a matrix, which is an inexpensive thing to do. And as Christy alluded to earlier, you don't want to find out that you are sharing the same linen service or pharmaceutical service as your neighbor hospital down the road. When Y2K presented itself, we were actually working on our MMRS grant at the same time. And we actually put together a matrix, and you're seeing it right now, where we listed our different resources that we had within our community. Every one of us had this available to us during the change at midnight, so if anything happened, we knew where we stood, and we're in the process of updating this right now. Every one of our EOCs has this, all the hospitals have this. It's a tremendous tool, and it's not hard to do.
Good point. Anyone else? All right, thank you, panel. So the next question, what sort of things should a hospital keep in mind as they try and synchronize their emergency protocols with other areas of the community, like fire and police, who have been out doing their own thing quite often?
I think it's clear to me that after having a number of years involved in disaster response training and preparedness activities, that if people don't train together, they can't expect to respond together. So that participation in community-wide drills or exercises are extremely important.
We've found that training and making, for example, our hazardous materials division within the fire department, part of our annual operations course has been very important, and it does 2 things. You don't want to get to know your first responders when they're bringing in a patient, because you haven't built that relationship yet. And in addition, they have taught us some tricks of the trade that they have at the scene that we simply haven't thought of in the hospital setting. So making them part of the planning and education process has been a real win-win situation for us.
And I just want to emphasize those points. You really do have to train together. When something happens, nobody's going to go to the shelf and pull up this big disaster plan.
That's right.
You have to go through a process of planning with all of your community partners to know what their capabilities are and know what types of things might happen. Practice, drill, practice, drill.
And part of the training is that you're going to see what systems you have, and do they fit into the systems that the community has, so that you really have to be looking at the interoperability of your systems and maybe even your technology to make sure that you're able to easily share.
All right, panel, thank you very much. So what sort of resources are available to communities and/or hospitals that are just beginning now to focus on emergency management? And you know there are a lot of smaller hospitals that are. They don't know where to start. They don't know where to turn.
Right. I think the first thing they can do is to look to their city planner, and everyone has one. And one of the questions I'm most frequently asked is, how do I do a hazard vulnerability analysis? What does that mean? Now, there are some tools out there that are free. You can get them from the American Society of Hospital Engineers. You can get them from FEMA. But just go through the hazard vulnerability analysis. I'm not going to plan for a hurricane in Salt Lake City. And up until 2 years ago, I had no intention of planning for a tornado, but I have since changed my mind. But it's just these kinds of things so that you plan for the realistic events and then go from there, because your hazard is going to define your response.
All right, panel, thank you very much. Let's move things forward now and focus on how hospitals that are already doing these things well, how are they doing it? And it's most natural to begin things here with you, Debbie. So in addition to the Olympics, have there been other catalysts that have spurred your community's preparation?
Oh, we've been unfortunately blessed with a lot of catalysts in the last few years. I referred the viewers earlier to page 23 in their viewer's guide with our planning guidance document, and that's what really began it for us a number of years ago, Janet. We've had a couple other incidents. You know, every community has, unfortunately, shootings or whatever. We've had that happen. We've had a few anthrax hoaxes, and the good news about those events is that we built on our CSEP experience, our chemical stockpile experience. We knew who was at the scene. They had our phone numbers. They knew how to contact us. We knew how to contact them. We knew how to contact our our partners in the health department, and as a result, things went very, very smoothly. And because we had been planning some of these things, we actually knew our counterparts in the Justice Department and the FBI, and that made the whole event go much smoother. So we've had a few events. They've gotten us thinking about stuff, and it's made our preparations for the Olympics go a little bit smoother.
All right, let's take a look at how well you guys are doing. We sent a field crew to Salt Lake City 2 weeks ago. The city was conducting an exercise combining federal, state, and local forces together to test the community's preparation to deal with a large-scale, criminally-oriented emergency. Now, the purpose to get ready for next year's Olympics. Obviously, this community gets a little more right now, federal resource-wise, than the rest of us do. But like we said at the beginning of the program, things are happening at the federal levels, and they will have an impact eventually. We need to build our capability at the local level and work with other hospitals for the sake of the communities we serve. Now, we had 4 camera crews shooting 4 locations real-time and simultaneously, 3 in local hospitals. Let's go to the first, the University of Utah Hospital, where Debbie is responsible for the emergency management plan.
The exercise involves a terrorist action during the Olympic Games. The name of the exercise is called the Wasatch Rings, and it involves a group who is unhappy with the Olympics for who never knows what reason, called rage, and they blow up a vehicle in a park and ride lot called Sugar House Park. It will not actually take place in Sugar House Park, but in another park in the Salt Lake Valley. The Rage group has actually stolen some nuclear material called strontium-90. Strontium-90 was in our atmosphere for years and years after the open-air testing, when the bombs were being blown up in Nevada.
The incident is scheduled to begin at 2:45 p.m. Some unforeseen logistical factors delay the start by several minutes. Over the course of the next 2 minutes, 911 receives several calls and then dispatches Salt Lake City Fire and Rescue units to Sugar House Park, which for the purpose of this exercise is in reality an equestrian park on the south side of the city. After the units are dispatched, E-Team software is activated.
Objectives of the exercise was to test, number one, our communications from the field to the operation centers and coordination centers and back to the hospital. Our ability to triage, treat, transport patients to the hospital and turn around and treat those patients again in the hospital within this unique environment that this particular event presented for us.
The hospitals are going to evaluate several things. Number one, can they take care of radiologically contaminated patients? What are their resources? What do we need to do better? The second thing we're going to test is our communication. We're also going to use some new technology involving the internet and an ability to report our bed capacity and any problems we have. And this is going to be the same software we'll be using during the Olympics. And the neat thing about this is there's interface between police and fire, and every agency can actually look at this, can use that information to help them coordinate. Finally, each hospital will use this as an opportunity to test their disaster plan. And then everybody has their own internal, what are we doing to test it, goals and objectives. We're redoing our plan, not anything different, but you know, we have staff turnover like everybody else, so we're using this a lot for education as well.
At 2:53, the Olympic Coordination Center is notified that a local radio station has just announced the explosion, and a local TV station dispatches camera crews and their traffic aircraft. At 2:55, emergency response forces arrive at the explosion site and begin reporting on the carnage they find. As additional ER units, accompanied by hazmat police, arrive on site, treatment begins. Triage and transportation of the injured to area hospital commences at 3:01.
Locally at the University of Utah, our Environmental Health and Safety Department provides core training for the University of Utah and for health sciences on how do you develop a plan, how do you do risk assessment, what are the core elements we want. I do planning for health sciences as well, and I meet quarterly with every member, every department director from health sciences to help them develop their plan. And make it mesh with our response, and in turn our response has to mesh with the campus response. It's an integration. And then informally we get together within the community.
At 4:31, Debbie Kim places a call to the OCC. This is a scripted inject. Supplies of potassium iodide, the prescribed treatment for strontium-90, are in short supply. She receives a phone call back from a representative for the Chemical Stockpile Emergency Preparedness Program. who advises her that additional supplies are en route and counsels that in the meanwhile that they use potassium iodate, which is also considered an effective treatment.
Hospitals need to really participate in their local emergency planning committee, LEPC, and traditionally that's been mostly members of industry who come and they talk about their trailer loads of chemicals or what's rolling through the yards. But that's where you find out who's the safety officer for chemical company X. And when you have an incident, whether it involves that company or not, you know who to call. And these people have resources beyond what we have in the hospital in terms of, providing us with material safety data sheets, industrial hygienists, helping us manage different incidents. They're really very, very important. So hospitals need to take advantage of their neighbors. They need to get to know each other and who's doing the emergency management planning. Not just within their own facility, but in every facility. And I would bet most hospitals, if you interview them today, wouldn't know who's the emergency manager in their closest hospital right down the road. They just won't know. We've been forced to do that because of the stockpile. And that's been the best thing that ever happened to our community. And it's gotten us ready for the Olympics.
Got a real one coming in.
At 4:40, activities at the University of Utah Hospital are suspended due to increasing real-world patient volume. For hospitals just now beginning to develop a more detailed emergency management plan to be in compliance with Joint Commission standards, Debbie Kim offers this advice.
To begin over a common problem that's in your community. Every community has a common something, whether it's the steel mill or the tire factory or the hog butchering facility. All hospital planning is to do a threat assessment. And once you've identified what's going to get you into trouble, then you need to identify who's going to come and be a partner in this. And what hospitals don't realize is that they have an incredible resource right in their own backyard with the fire department, with the police department, with members of industry. But that's how you begin. You don't make it a big deal. You don't make it as threatening as it could be. And remember, a lot of hospitals, there's tremendous competition for patients. There's a lot of history in communities. And so neutral territory over food is a good place to start. And just to exchange telephone numbers and names and pager numbers and cell phones and have somebody make a matrix and then bring in your support people. The fire department, find out who the fire chief is and who on his staff, either a captain or battalion chief, is responsible for maybe special operations or hazardous materials, and get to know them and then bring them into the planning and write your guidelines. These are the people who can help you with planning. They're familiar with all the NFPA standards, and they'll make your life much easier.
And we'd like to let you know, no stuffed animals were hurt or injured in the making of this film. A little levity here. What's with the stuffed animals?
I just want to report that they're all okay.
Good.
Decon was a little tough. Decon was tough. We used the stuffed animals for a reason. The exercise took place right at change of shift, typically change of shift. And it was a bad time to get high school students and whatnot. In fact, the group that you saw was actually at the drama club from one of the big high schools. And no one wanted to volunteer. So being fiscally conservative, I had to look for other resources, and I turned to my children. And I had to go through a stuffed animal review board before I could have them be used. So you saw a large collection of my kids' stuffed animals.
But that's a wonderful way to conserve costs.
It was tough when you were trying to do, interviewing with how they were feeling. They really weren't talking back. But anyhow, that's why we used it. We didn't want to use paper. We wanted to use something that people could actually practice their surveying on and touch. And it meets the Joint Commission standards, so why not? And I didn't tell anyone about it. And so the neat thing was when the stuffed animal showed up, they said, "What is this?" They had these little tags on them with their injuries, and then they realized, oh, these are the disaster patients.
So what did you guys learn from all of this?
Oh, we learned a lot, Janet. The first thing is I want to point out there was an inject that you saw on the tape where I was calling into the Olympic Command Center, the OCC, about getting some potassium iodide. And then I was told, no, we could use potassium iodate. And that's really not something we would use with strontium-90. But we we, meaning the hospitals, didn't have an opportunity to participate in the development of the script for the exercise. It was presented to us as a fait accompli, and when we sat down the day before the exercise and started to discuss how things were going to flow, the people who had written the exercise had no clue about how our community worked, and so we had to change things slightly. So I just didn't want the viewers to think that we were using something that was inappropriate. The one most important thing we learned was communication. You saw us using our handy talkies. We tried out that new web-based communication tool called eTeam, and it worked okay. We had problems with hardware. Couldn't log on a few computers because of some firewall issues. The screen that was for hospitals really hadn't been updated as we had hoped. So it was a good tool. It's not the be-all that end-all. We need to train more on it. We also used some of our new communication technologies called 800 megahertz radios. And we, during our tornado a couple of years ago, we found out we couldn't talk. We could not talk. Fire was on a different channel than police, than hospitals. So 800 megahertz helped somewhat, but not all the hospitals were up on it yet. It's expensive technology. One of the other things that we learned is there was a tremendous competition for control at the scene, and we've seen this with real-life incidents. And when you inject a new layer of command and control, which is what's going to be present for the Olympics, it was hard to figure out where they fit with real-life things. So that was a challenge. We had some challenges getting the information back to us. You know, the hospitals never really were told that they were dealing with a radiological contaminant. As a controller, I knew that, but we never received official notification, and that could have been disastrous for us, no pun intended. The other thing that was interesting in hearing the debriefing from the city planners was that the control issue between the responding agencies. And Janet, we had 75 federal and state and local agencies responding to this exercise. So for them to figure out how they were all going to talk to each other and who was in charge was a real challenge. The FBI thought they were in charge. The state police thought they were in charge. The Salt Lake City police said, well, no, we're in charge. And then when it came to my hospital, you know, the university police thought they were in charge. And then the hospital administrator said, well, what about me? So, you know, we had some real legitimate issues here that we needed to address. All in all, we learned some good lessons, and we're getting closer to being ready for the games.
These type of interagency drills are really important, but there's a couple of pieces to them that people don't always think of, and that is you need some type of education and training before the drill. Otherwise, it's sort of like taking the final exam when you never even studied for it. And you also need to debrief after the drill, sometimes called a hot wash, to see what you can learn from the drill itself. That's just critically important. If you have a drill and you come out and you said everything went perfectly, that's a pretty worthless drill in my opinion, because you didn't learn anything, which is the purpose of doing the drill.
Christy, you're right about that. You know, I'll tell you, our hot wash after this exercise was brutal. It was, the gloves came off, and you know, there was no sparing anybody in terms of them not knowing fighting the hospitals and the command and control issues. One of the big issues, interestingly enough, for our mayor was that he couldn't get real-life information in a timely manner. Our mayor is a lawyer. He wants everything yesterday. And we had a little reality check from a colonel from the Pentagon who was an observer who reminded us that very often the media provide a huge amount of information in this kind of situation, and that, you know, get used to it. That's how you're going to get your information, right or wrong.
Exactly, good points. I thought the film clip had some good points in there. One was the multiple sectors that had to work together. But the important thing I want to make is that once you move from the scene and securing the scene from the crime scene or from the event, you've moved into a health emergency involving a hospital.
That's right. And it's different. It's different.
It's clearly
Patients
different.
are first.
All right, thank you, panel. What kinds of activities should be performed on a regular basis to ensure that a community and/or a hospital is as prepared as it can be for an act of terrorism involving a weapon of mass destruction? So this would include drills and other things. Are there other things that hospitals can do to prepare?
You might want to start by looking at what you have for your own resources. For us, we have one Geiger counter, and it's in our emergency department. I was really pleased to find out that if I went down the School of Medicine hallways, I could find little signs that had radioactive logos on them, and guess what? They had Geiger counters too, so we had a chance to start doing inventory and find out where our things were.
That's a good point.
want to go back and emphasize the comprehensive emergency management approach. There's a real tendency with this WMD to say we have to go out and prepare for bioterrorism or chemical terrorism rather than having a basic emergency management plan in place and building from that.
That's right. Very good point.
Right. I'd also like to mention another community resource. Many cities, large cities, have metropolitan medical response systems. They're part of the Office of Emergency Preparedness, which is part of the Health and Human Services. And these can serve as a community-wide resource for your health and medical planning.
All right, panel, thank you very much. Let's move to our second hospital, LDS, part of Intermountain Health System, or Health Care, a system with 5 hospitals in the city. Now, we placed a crew there to show their experience, so let's take a look.
All hospitals, this is an exercise from State EMS.
The call came later than expected, but when it finally did, everyone was ready. A terrorist bomb just exploded at a park and ride lot on the edge of town. The voice on the radio reports 500 blast-related casualties involving a radioactive substance.
Get the key. You know where the key is, Sean?
Right now, all Salt Lake Valley hospitals are busily setting up triage and decontamination units for the injured. Though it's only a drill, there's a feeling of urgency here at LDS Hospital. The Olympics are just 300 days away, and memories of the pipe bomb explosion in Atlanta are still fresh. This exercise will gauge how well the staff and the hospital's emergency response plan hold up to a major catastrophe.
9 patients.
Meanwhile, in a conference room not far from the ER, the hospital's command center is buzzing. This is where hospital staff coordinate patient transport with EMS and other hospitals. Everyone has a role to play, from tracking victims' medical needs to communicating with the multiple agencies and facilities involved in the drill. Ann Allen is the emergency management coordinator for LDS and 2 other hospitals. Today, she is observing her emergency response plan in action so that she can make adjustments for the games.
One of the biggest goals I have, at least as doing the emergency management planning for the hospitals, is how we interact with pre-hospital. What kind of information are we getting, how good that information is, and how well we can receive it within our hospital. That's really critical for us. One thing we want to make sure we can accomplish is how we process our patients, how we track our patients from pre-hospital to hospital. When a patient comes in that needs to be deconned, we might not only be dealing with a patient, but we might be dealing with the perpetrator as well. So it'll be really critical that as we're deconning this patient, that we properly label the patient as well as the patient's clothing and their jewelry, that we can positively identify that this patient that came into our facility belongs to this set of clothing. That will be important for the FBI when they come in to do their investigation.
Here in triage, doctors assess patients and send them to green, yellow, or red zones inside the hospital, depending on the injuries.
We know she's got, just from a patient number 1 red tag, go through here, and then she can get up and walk away.
The tent is considered a hot zone, so only those in hazmat gear are allowed inside. Even though decon for hazardous agents was conducted in the field, doctors chose to wash down several patients that may have been missed. LDS received 16 patients during the drill, all of whom were admitted for blast and radiation-related injuries. To minimize disruption, planners kept the number of patients to between 16 and 25 for each hospital. In the event of a real mass casualty incident, many more patients would have been sent to LDS. Nevertheless, this was a good, scaled-down rehearsal for an event that no one wants to experience for real.
Your support is documented and appreciated.
Overall, everything went smoothly with only a few glitches. This was a unique test because it involved large-scale radiation exposure and evidence collection, circumstances Salt Lake hospitals must be prepared for during the Olympics. With a little revision and work, the hospital's emergency response plan should be able to handle a major incident like this one. For those hospitals developing or testing their own emergency plans, Ms. Allen offers this advice.
If a hospital was trying to find a starting ground, trying to look at what they need to do. Joint Commission now requires that they do a hazard vulnerability analysis. What we've found is all the cities and all the counties are required to have it by law already. There's no reason for them to be reinventing the wheel again, per se. So what I would suggest that they do is that they go to their county and talk with their fire department. They already have the plan in place, and they can already look at their hazard vulnerability analysis, and it's a great starting ground to look and see what kind of hazards you have in your own facility. From there, it's just a simple little matrix, and they've already got it in place. You can just review it and adapt it to your own facility, and you've got a huge process already out of the way that will actually get you going in the right direction and get your facility a little safer than it already is.
So panel, let's get your comments to what we just saw at LDS Hospital.
This scenario raises some very important points. If you're dealing with a situation, in this case radiologic contamination, could also be chemically contaminated patients, you cannot count on your EMS system, your pre-hospital providers, decontaminating those patients before they get to your hospital. Some patients may come by private car, they may walk in, you know, you're like a beacon out there, they will come to your hospital. So you need some system for decontamination, and that's one of the things we're struggling with, is what is appropriate in a hospital setting. One of the interesting things here is they had physicians doing the decon, and some people would say that, particularly if you have a limited number of physicians in your emergency department or your hospital, that you might want to save those healthcare practitioners for actually taking care of the patient rather than putting them in suits and going out and doing the decontamination.
Yeah, Chris,
good point.
You're absolutely right. You know, we have had just the opposite experience at the university, where there hasn't been that many physicians that have wanted to go and get dressed out. A couple of them just because that's what they wanted to do. But you're absolutely right. We need to save those resources almost in the back a little bit to do what they're best skilled at doing. At our place, we've cross-trained police, we've cross-trained security, and any of our nurses who do decon have to be trained to operations. And again, the more we train, the more people that learn the process, the better off we're going to be, because we need people to be able to slot into those roles.
And another challenge for hospitals is what level of personal protective equipment, or PPE, do those personnel receiving patients from the scene need to wear? Is it level A, level B, level C? It's not simply a matter of money either. Level A, which is the most protective and the most expensive, takes about 30 minutes or so to get into. By that time it may be too late, and you can't necessarily stay in it that long, and it's very bulky. You can't take care of a patient while you're in that suit. So these are very complex questions that are challenging for hospitals.
Right. And there's not, and the challenge is finding out where the rules are written that apply, and everybody seems to have a different spin on it. What do you say, Bob?
There are two things I particularly liked about the drill. One is that you could see that there is a performance improvement eye throughout, that people are there looking to see what are the issues, knowing that there are going to be more opportunities to do this before hopefully the real thing ever occurs. And the other thing that they show is that there is a concept of they are thinking about incrementally expanding what they're having. They know that what they're doing here isn't going to be big enough, but it's a great model to start with, and they learn the mistakes small, and that they can continue to make it bigger and more complex as time goes on.
Exactly, starting with a emergency management plan to deal with a large scale, from a small scale to a large scale type of emergency. Extremely important. All
right, thank you, panel. And our final visit to Utah takes us to the VA hospital. But before we go there, Christy, why would the VA be involved in something like this? I think a lot of people assume the VA is just there for veterans.
I'm really glad that you asked that question, and definitely the VA's primary role is caring for veterans, but we also have a role in our communities. In fact, one of our major strategic goals is building healthy communities. So we need to plan, just as we've been talking about all along this broadcast, about how do we assist our communities when there's a catastrophic event.
All right, thank you, Christy. And let's take a look at the VA in Salt Lake and see how they handled the situation.
That is foremost for me is the ability to coordinate and communicate among the hospitals here locally. We've made great strides in improving the coordination and the communication among the hospital, and I think NDMS has been important in that arena, but we still need to coordinate not only among the hospitals, but also among various agencies at various levels, both local, state, and federal. And I feel like as the federal coordinating center, one of the things that I hope to solidify is the understanding that things roll up at the local level to the next level and then beyond that. And hopefully that will be done in a manner that is consistent with what all of our plans say is supposed to happen.
The hospital's first inject happens at 2:48 when the Olympic Coordination Center notifies the Joint Operations Center of the incident and follows this action by distributing the information to local hospitals. Leonie Monroe, upon receiving the information, activates the EOC and the hospital's disaster plan. Triage and transportation of the injured to area hospitals commence at 3:01. The VA hospital receives notice that the first casualties, a total of 4, are headed their way. In response, they set up their internal triage center, mobilize additional staff to help with triage and transportation within the hospital, and begin processes to ensure that there will be sufficient manpower to handle the crisis.
There are 2 other individuals that I work very closely with, and the other 2 musketeers are Debbie Kim and Ann Allen, both whom represent the 2 largest hospitals within Salt Lake City and are both participating hospitals under the NDMS. When I came here 5 years ago, the functioning or the management of the NDMS belonged to Hill Air Force Base, and a year and a half or so after I came here, that transferred to me at the VA. And we have established a really good relationship among the 3 of us, Debbie representing the University of Utah, and then Ann Allen representing the IHC hospitals, but at LDS specifically. And what we have decided among the 3 of us is there are a number of events that drove developing a good relationship. And in the throes of a disaster is not the time that you want to get to know your neighbor. And I consider both of those individuals good neighbors, and one that in the event that we would be required to call upon each other, we know that those resources and that support is there for us.
At 3:10, various agencies throughout the city received word that there are approximately 500 casualties from the explosion, with at least 50 to 60 dead, 300 with significant injuries, and 100 with minor injuries. Injuries are primarily blast and fragmentation wounds. Leonie Monroe receives a call from the OCC Help Desk. The National Medical Response Team, pre-positioned for the Olympic Games, want to know if their assistance will be required. Leonie, the area emergency manager, places a call to the Public Health Service to initiate the federal response plan, thereby mobilizing additional resources for the entire community.
As the NDMS coordinator, I am asking that we go through the formal chains and to let you know that I am going to request a DMAC for this facility.
At the same time, the incident commander requests that at least 1 disaster response unit be dispatched to the Sugar House Park Incident Command Post.
We have 23 hospitals that sign a memorandum of understanding that in the event that either a natural disaster overwhelms an area outside Salt Lake City, or in the case of a military contingency, we activate those hospitals within Salt Lake City to receive those casualties. There's a reception plan that calls for the mobilization of local resources to an area that where that plane would come in for those patients, and then ultimately those patients would be sent to the local hospitals.
Leonie Monroe, on behalf of the VA hospital, calls the OCC Help Desk to verify that some victims sent to the hospital had been exposed to radiological contamination and that they had been decontaminated at the scene before being sent to the hospital. Shortly thereafter, the VA hospital now begins diverting patients to other area hospitals. While they have plenty of beds for incoming patients, the hospital's 2 operating suites can't handle any more patients, so triage patients requiring surgery are diverted.
Surgical is full. They cannot accept any more patients. They request that we divert from this point.
Following completion of the exercise, the hospital deactivates the EOC and reverts to normal staffing. The next morning, like the other hospitals participating in the exercise, they debrief.
I would recommend that if, in a small area, if a hospital wanted to become a leader or wanted to take charge of an area in terms of increasing their readiness, that you have someone, a champion, if you will, that will take lead and just look at what risks are locally there, what risks might drive a response in that particular area. And even though an area is not deemed an NDMS area, I think that it's prudent for planners, emergency planners, whether they be at the hospital level or within their local jurisdiction or community, for them to look at what their risks are and just to decide that this is something that they're going to take on.
So panel, let's get your comments to what we've just seen.
Well, I'm really pleased we saw this segment because Leanne's done an excellent job of illustrating VA's role in the local community. And if you would like assistance through the Department of Veterans Affairs with resources in your local community, you can contact people like Leanne, called Area Emergency Managers, by going to the website, which is displayed on your screen, and looking up who's close to you that might be able to help you get connected with other community partners where you live.
Good point. Just want to mention a couple things that were really unique to this drill, because I don't think our viewers may have appreciated that. Leanne talked about activating the DMAT teams, and that was actually one of our community goals, is how do we go ahead and ask for federal resources. Understanding that in this exercise, the Disaster Medical Assistance Team, or DMAT, was pre-positioned as they are going to be for the Olympics. That's not something a community would normally have.
Good point.
And that made us think about how we ask for the help, because there's a little hill you have to climb over. As Christy will tell you, you can't just pick up the phone and say, I need help. It doesn't work that way. There's certain declarations that have to be made by senior government officials before those resources can come into play.
It's a really good point, and it again illustrates that disasters are local. There's sort of two different scenarios. There's a scenario where it is a high-risk event like the Olympics, where there will be federal resources staged or positioned ahead of the event in case they're needed. But if something happens that's an unplanned emergency, you will need to contact your local health department, your local emergency management, and go up through the state and up to the federal level, and it will take some time before those resources get to you.
Absolutely.
Very good. And another part of the clip we just looked at, clearly it shows that hospitals are part of a larger response in the community. And the second, that once an event has happened and there's been an explosion or a release, really the hub of activity moves into the hospital. They become a key focus point of the disaster response. And that if in a local community your hospital collapses, then the ability to attend and address the needs of patients is markedly diminished.
That's right. Good point. All right, panel, thank you very much. So what kinds of advice do you all have for hospitals as they think about how to interact with the media in the case of such an event? And Debbie, you alluded to that earlier, and I think we've all had that experience. It can be tough.
It can be real tough. One of the things we found out with our tornado is that the media drove the action. The media unfortunately didn't know that the tornado had gone up on top of the mountain and gone over, and the scene of destruction wasn't just downtown. So getting to have your public affairs representative, or in the jargon of incident command, the PIO, Public Information Officer, get to know who their counterparts are in the community is very, very important, so that events can be coordinated and our response can be spoken with one voice. I think it's important for hospitals to realistically understand that the media will drive the action. They may drive patients, they may have inaccurate information, and it's important that we have a mechanism to get that information back to the media to correct any misperceptions that's going on.
The media are absolutely critical to your planning. We've talked about over and over again how communications are a problem during disasters or emergencies. They're not reliable. But now, in this day and age, you know, you can watch the war on CNN. It's absolutely incredible. The media are communications experts. So you really need to get to know them ahead of time and bring them into your planning so that you can use them to help disseminate important public health information when something happens.
I would certainly agree. I wouldn't underestimate the benefit of a little training in handling or managing or working with the media. It also should be part of your planning. And I think that some of the lessons learned in previous disasters is to have regular contact with the media, be honest, and have a way to contact and keep those channels of communication open.
Absolutely. Because they are not going away, and that's something you have to deal with.
That's right.
Just a final point is it shows that a well-done drill is really a soup to nuts. It's not just the medical piece, in that it includes everything, things that you wouldn't necessarily think of would go into a drill.
All right, panel, we do have a caller online. We have Bruce, who is calling from Ann Arbor, Michigan. Bruce, welcome to the program. What's your question for our panel?
Yes, I wanted to find out, in terms of incident command, is incident command specifically required within the Joint Commission standards?
The wording that's used is that there does need to be a command structure where people who are doing one thing should be able to do something else, and those people should also be able to fit in the work of the community. So that word incident command structure does not sit there, but command structure does, and that's basically what it's describing.
We actually discussed that on the Committee of Healthcare Safety, on which I sit, when we were developing these new standards. And rather than being prescriptive and saying you have to have a certain type of incident command system, we said an incident management system, and gave the example of HICS that we mentioned before. But you can really use whatever would work in your community as long as you do have this command and control structure in place.
Right. I think the important thing here, Bruce, is that it points out that when you have an emergency situation, business as usual stops, and you're going to have a system that assesses your hospital and your community at that time and what your resources are. And it needs to be dependent on not just one person being there, and incident command gives you that flexibility.
Exactly.
All right, panel, thank you very much. And Bruce, thank you for your call. We appreciate it very much. So, panel, what are some of the less easily recognized warning signs that should trigger a call from a hospital to other agencies regarding a potential bioterrorism attack?
Well, let me add that the hospitals or the clinical community may be the first focus, or become the first components of the community aware of there may be a problem with an epidemic caused by bioterrorism. It could be increased numbers of patients with flu-like illness, large numbers of people suffering from an illness that's not seasonal, or quite frankly, an announcement from a threat letter.
Anyone else?
Just to build on what Scott is saying, most emergency departments have an informal network if there's more than one hospital involved, where you'll be on duty and you'll start talking amongst yourselves and say, you know, this is the 6th case of flu and it's July. What's wrong with this picture? And you pick up the phone and you call the other hospital. Are you seeing the same thing too? And I think once you begin to get your local intelligence together, then it's time to say, okay, we need to call health department and let them know something is not right.
Exactly. Don't underestimate the importance of your hospital-based epidemiologist or practitioners of infection control in their ability to communicate with each other or the county health officer.
All right, panel, thank you very much, but I'm afraid we are about out of time for this program. Bob, Christy, Scott, and Debbie want to thank all of you for being with us. It was a great show today, very interesting. And our next JCSN broadcast, Electronic Medical Records, Information Security and Data Recovery, will air on Thursday, May 17th. And immediately prior to that broadcast, we will air the latest installment of the Accreditation Update. If you are a new JCSN subscriber, Accreditation Updates are short, concise programs that address topics outside of our scheduled teleconference titles. We air 5 Accreditation Update programs per year, and each of them focuses on specific Joint Commission issues, including new initiatives, survey process changes, and revisions to standards. Accreditation Updates are available to JCSN subscribers only and air immediately prior to select JCSN video conferences. The next Accreditation Update on critical access hospitals is scheduled to air immediately prior to next month's Electronic Medical Records video conference, so be sure to join us then. And before we leave, I would like to thank all of our subscribers who have called in with some very good questions for improving our programs. JCSN will continue to incorporate those suggestions throughout this year. So if you have any ideas for how JCSN can better serve your organization's needs, please email us at jcsn@pwpl.com.